Neuroradiology session. We will start with Dr. Tarek Yousry. I don't think that anybody doesn't know Tarek. Tarek is the head of the Division of Neuroradiology and Neurophysics at UCL. He's head of Lisham Department of Neuroradiology in London, director of MSc in Advanced Neuroimaging. Tarek is the president of European Society of Neuroradiology. He will start the session with a talk about gliomas, imaging, and WHO 2021 classification. تفضل يا طارق.
Thank you very much, Ahmed. I'm delighted to be here, home country. And as the president of the European Society, I would like to convey my warmest wishes. The Egyptian Society is a member of our society now. We have a memorandum of understanding, and part of this is that we have a joint session now at this national conference. So, delighted to see you here. I know that in Egypt we don't always have a full complement at 9 o'clock in the morning. I completely understand that. But for those who are here, I hope you will enjoy this joint session. So over the next 25 minutes or so, I'll start a little bit with an introduction on the principles of the WHO classifications. I'll focus a little bit more on the astrocytomas, and then I'll speak about some MR characteristics that may guide us in terms of identifying the subtypes. Any classification has a purpose. The purpose usually would be to define a biological behavior, to determine prognosis. If the classification doesn't help us in understanding the prognosis, there's no need to have this classification. Knowing the prognosis and knowing the biological behavior should help us in advancing concepts of treatments. So over the years, the first classification was in 1979, and the last one was in 2021. 1979, the first agreement was based on histological criteria. The grading was 1 to 4. I'll come to that in a second. And the concept of anaplasia was introduced. A big step came in 93 when the integration of immunohistochemical features was introduced. 2016 was the next really big step with the introduction of molecular genetic features. And this was followed with a flurry of updates, which culminated in the 2021 classification with a clear emphasis now on molecular and genetic markers. So the WHO classification 2007 is the one that's quite ingrained in our daily work. It's classification based on histogenetic concepts using light and electron microscopy and immunohistochemistry. It is based on assumed, on putative cells of origin and developmental differentiation states, and there is a supplementary information on genetic status which has been included. So you all know the classification based on the original cell type, the assumed original cell type, astrocytoma, so oligodendroglioma, or a mixture of the two oligoastrocytomas. The grading, you again know the grading, grade 2, 3, 4, in Roman numbers. So based on atypical cells, mitosis, and then vascular proliferation and necrosis. And then you have very specific forms, which are like pilocytic and so on. The 2016 classification is also based on histogenetic concepts, but has additionally introduced genetic parameters. So these are the genotypes. What has changed? There has been quite a change in terms of family trees. Previously, until 2016, all astrocytomas were together. Now, all diffuse gliomas are together. So you have the astrocytoma 2 and 3, oligodendro, and so on. That was the classification, and you have now also introduced diffuse midline glioma, which I will not go into detail. So that is the concept of 2016, that you have diffuse astrocytic and oligodendroglial tumors, and then you have other circumscribed astrocytic gliomas. So in 2016, we have this diffuse astrocytoma and, and anaplastic astrocytoma. Each one of them is divided into IDH, mutant, or wild type. IDH mutant or wild type. Or if we don't know the IDH status, then it is not otherwise specified. The diffuse is grade 2, Roman. Anaplastic is grade 3, Roman. But as I said before, since 2016, a lot of advancement happened, and these were published in what was called a Consortium to Inform Molecular and Practical Approach CNS, in short, C-Impact Now. There were 7 which were introduced, and in one of them it was seen that the IDH wild-type astrocytoma, the wild-type astrocytoma with molecular features of GBM, glioblastoma, grade 4. So this has a poor survival, similar to the survival of general GBMs. However, the clinical, radiological, and histological characteristics are those of grade 2 and 3. So this was an entity which looked on images like grade 2 and 3, but actually the biological behavior was that of GBM of grade 4. So the 2021 classification is much simpler than anything before. You have astrocytoma, which are mutants. You have oligodendrogliomas, which are mutant and have a co-deletion of 1p19q. And then you have GBM, which are wild type. Wild type is GBM. That's it. You don't have a GBM anymore, which is mutant. You only have GBM, which is wild type. If you have it mutant, it's either astrocytoma or oligodendrogliomas. So again, to make that clear, the recommended grading and terminology has changed. We don't talk about anaplastic astrocytoma anymore. We talk about astrocytoma mutant, grade 3, and to make the change clear, we're using what they call now the Arabic numbers. So we have now, instead of the Roman numbers 2, 3, 4, we have here grade 2, grade 3, grade 4. So this is the major change. It is a simplification. But there's a problem, of course, if you go to the older literature or to the very recent literature, where you have the basis of the subdivisions. Here again, astrocytoma, now focusing on the astrocytoma. Diffuse is just astrocytoma mutant, grade 2. Anaplastic, astrocytoma mutant, grade 3. And GBM is grade 4. Sorry. GBM in the old classification is now astrocytoma. This was mutant, is now grade 4. It is not called GBM anymore. GBM is only when you have the wild type. And this should show you how the approach in general is. How do you start? You start by knowing what is the IDH status, mutant or wild type. Wild type, you end up with GBM. Oops. If you are on the mutant side, the next thing will be co-deletion or not co-deletion, and then you get into oligodendrogliomas or astrocytomas. What is important also is, of course, why do we do all this? We do all this to be able to manage the patient better, to offer a better treatment, to have a better characterization of the patient's tumors. So every one of these, oligodendroglioma, grade 2, grade 3, or astrocytoma here, grade 2, 3, 4, they have a different treatment regime, which is why it is so important to know that grades and to know it accurately. So how does this influence, or what's the relationship with the images? You saw that the key was to identify the IDH status. So this is what we are trying to do, to help identifying the IDH status. What are our tools? Our tools would be contrast enhancement, T2 flare, mismatch, DWI, restriction or not perfusion, and spectroscopy. So if you look at the contrast enhancement, and most of us grew up understanding that when you don't have contrast enhancement, it's usually lower grade. if you have contrast enhancement, usually higher grade. But I showed you before that there is a group of patients which have IDH wild type, look like histologically grading 2 or 3, but from a molecular point of view are grade 4. So these usually do not enhance. So looking at, so already there is an uncertainty about the relationship with enhancement. So looking at the oligodendroglial type and the astrocytic type from a molecular point of view, you see that from the point of view of diagnosis, starting of diagnosis, the progression-free survival is quite close, and here is quite different from the GBM type. Okay, so that's the basis. If we look at survival in terms of contrast enhancement in the oligodendroglial type, there's no difference. In the astrocytic type, there's no difference between enhancing and non-enhancing. In the GBM type, again, no difference. So there is no clinical difference that allows us to say when there is enhancement, there is a worse prognosis. However, what about the pattern of enhancement? If you have no enhancement, as you have here, the blue one, or just a faint enhancement, the clinical behavior is quite similar. What is different is if the patient shows a nodular or ring-like contrast enhancement. So this is the big difference, maybe, and this is what we have maybe to focus on a bit more. The summary of a systematic review. So these are a number of papers which were analyzed and the information was pulled together and looked at sensitivity, specificities, and so on. And the conclusion was that there is no reliable WHO grade prediction based on contrast enhancement on its own. That's it. So you have to be very, very careful about the kind of enhancement you're seeing. However, if you have a ring enhancement, so it's not the fact enhance or not enhance, it's the shape of the enhancement. Maybe the ring enhancement with central necrosis increases the likelihood that we have a wild type GBM glioma. The very interesting thing that came up a few years ago was the T2 flare mismatch. What do we mean by that? We mean by that you have on the T2 images, like you see here, hyper-intense lesion, which is homogeneous in its signal. On the flare, you typically have a hyper-intense rim and a hypo-intense core. And you see the same here. Homogeneously hyper-intense on T2, but on the flare, the center is hypo-intense. Now, this is a very valuable sign. If you have it, then the chances for this being IDH mutant, not co-deleted, is quite high. However, there is no distinction between IDH mutant with or without co-deletion, which means we cannot separate here oligodendrogliomas from astrocytomas. Behavior is different. So if you look again at the grades, this was, as you see, since this is the Roman grades, that was before 2021. 2/3 of grade 2 have a mismatch sign, which means they are IDH mutant. 3/4 in that group of patients had the mismatch, again showing that there is IDH mutant. None of the higher grade here in group G, which was the GBMs, had that mismatch sign, means it was the wild type. The prognostic effect of identifying the mismatch sign within IDH is not very big. It's not very clear that seeing or not seeing it in an IDH mutant group will have a better prognosis or not. So taking a few characteristics together, like the mismatch, younger age, larger size, will give you a very high specificity and sensitivity is minimal because it doesn't occur so often, but when it occurs, specificity is very high, positive predictive value is very high. So seeing it is powerful, not seeing it does not help you very much. Why do we have the mismatch? How does it come about? It is thought that it's influenced by the presence of so-called microcystic changes with wide intracellular space and probably also the overexpression of a certain gene. So there is a pathological structure underlying this sign. Looking at diffuse astrocytomas and looking just in terms of view of images and trying to differentiate the wild type from the mutant, here's IDH mutant, here's wild type, what are the biggest differences? The biggest differences are that the wild type is more often multifocal, occurs more often in the brainstem, and does have less cystic changes. So these are signs that can help, but of course you don't get certainty about them. So that was about first gadolinium enhancement, then the mismatch. Now let's look at the other characteristics such as diffusion. Looking at the diffusion, there is, very simply with the ADC, you can see differences between, significant differences between the wild type, between the mutant and the wild type, but you see there's a big overlap between the two. So predictors can be a low ADC, although there is an overlap. So like everything, it is not 100%. How do you do this? You have two options. Either you go with a volumetric approach or you go on a single slice. Single slice is, of course, easier for us because that's what we do routinely. And putting a cutoff figure can help with differentiating the groups from each other. So the wild type is lower than the mutant with or without co-deletion. What about perfusion? Many of us are using perfusion. It's not advancing? Well, it's not advancing. No. Yeah, now it came, thank you. So I'll just show you briefly. Yes, okay, very briefly. The mismatch is seen particularly on the astrocytoma group, and it is not seen on the GBM group. There is no big difference in the biological behavior, whether you find or you don't find a mismatch. If you put together the mismatch with a lower age of less than 40 and higher big size of a tumor, then the specificity is very high. You can almost be certain that this would be a mutant. It has a very strong positive predictive value. However, since it doesn't occur that frequently, the sensitivity is low. And then there is a biological, there's a biological underpinning of this mismatch, in that you can have usually microcystic changes, you can have also wide intercellular spaces, and often an association with an overexpression of a certain gene. If you compare mutant with wild type and look at all these characteristics and try to see what is more one than the other, then the multifocality will be higher in the wild type. Also the brainstem involvement, higher in the wild type. However, the cystic changes will be higher in the mutant. So that's another way of trying to find ourselves in identifying the mutant from the non-mutant from the wild type. Looking at DWI and ADC, there are significant differences. However, there's an overlap in how much they can extend. And low ADC can help It depends how you do it. So usually the wild type has a lower ADC than the mutant type. If you look at what most of us are using, the single slice, then you can get a higher sensitivity and specificity, and this is seen here in the box plots. So you have here the mean is lower, but you still have a bit of an overlap, especially when it comes to co-deletion present or non-present. Now, coming now to the perfusion, which is something most of us are doing and applying. How does this help in identifying the IDH status? Well, not very much. You see here quite an overlap. There's no significant difference in this work. And in a systematic review, which was done a few years ago, they said that the evidence that is available is limited. So you have papers showing there is a difference, other papers showing there's no difference, and if you put everything together and try to come to a conclusion from the literature, you will see that the differences are not specific. So it's difficult to predict. If you combine now, we looked at individual features. If you combine features, so gadolinium behavior with ADC, with CBV, and on susceptibility-weighted images, look at whether you have intralesional susceptibility changes. The more you get, the more you put together, the more your sensitivity and specificity becomes, and that's clear. However, one needs to think about how you use that really in clinical daily routine. What was really interesting about the IDH mutant or not, IDH status, is that there is a biological sign by which you can measure directly whether it is mutant or not. It is because there is an oncometabolite, which is called 2-HG, hydroxyglutarate, which we can see through spectroscopy. So using spectroscopy, you can see the 2-HG, and you see it here, where it is. It's a very tiny, very small peak next to glutamine and glutamate before the NAA. So seeing this gives you a direct information of the presence or absence if you get it right. And that's a problem from a technical point of view. It's a small peak that you can see. However, can be clinically, in your clinical, can be challenging. So it's quite difficult to see it here on the short TE. It's much more easier here to see it maybe on this one with a long TE. So the technique you apply also gives you variable results. Looking at grade 2-3 glioma, again, this was published in 2016, so that was before the 2021, and therefore you have the Roman numbers. They found in the mutant, that was a pathological correlation, they always found the 2-HG metabolite, and but they did 37% of the wild type. In a clinical study that was done, they had that's the normal life. You have false positive, you have false negatives. So they had a cutoff value by which we said if it is above, then it is present, or below, then it is absent. They got a very high sensitivity and specificity and a very good positive and negative predictive value. These are two which they got wrong, where they had here a false positive. They thought it was a mutant, but it turned out to be GBM, and this was a false negative one. It's difficult to make a conclusion out of these, and that's the limits of the methods. So the status can be deduced by a combination of looking at the MR features, mismatch, ADC status, spectroscopy is one of the strongest, and obviously looking at size and looking at older age. So I'm concluding. The WHO classification in adults is based on simplified forms. You have astrocytoma, which have grades 2 to 4, a presence of IDH mutation. Oligodendroglioma, you have two grades like before, IDH mutation, like astrocytoma, but it has the co-deletion. That is the critical point. GBM is wild type by definition, and that's what makes the diagnosis. And you have here also different age accumulation. Then you have the pediatric types, of which I am not speaking. So if you want to understand what happened from 2007, 16, 21, so when you deal in your clinical routine and you get a pathological workup, or you look at the patient, what he had 5 or 6 years ago, you need to understand how things have changed. So oligodendroglioma is the same, has not changed, grade 2. There is, within grade 2, a change in that the oligoastrocytoma, here, oligoastrocytoma, grade 2, has changed in that it has been differentiated into the astrocytoma part and the oligodendroglial part. So now the oligodendro, what we call now oligodendro, is the previous oligodendro plus one part of the oligoastrocytoma. The other part went into the diffuse astrocytoma. You have what was called anaplastic. Anaplastic has disappeared. All the anaplastic words have disappeared. And the oligodendroglioma grade 3 is an oligodendroglioma grade 3 Arabic number. The diffuse astrocytoma grade 2, what was in 2007, has changed, and you have two components. One, depending on if it is mutant, then it goes here into grade 2. If it is wild type, it goes into GBM. And also, the other mutant here, you have in GBM, what was in the 16 classification, GBM mutant, is now grade 4 astrocytoma. So the word GBM has also changed in its meaning. You have to be careful about this. And finally, all the mutants are grade 2, 3, 4 astrocytomas, and the GBMs are all wild type grade 4. So what we had in astrocytoma, these differences, low grade, high grade anaplastic GBM, that has changed. In 2016, you saw this before, diffuse astrocytoma and anaplastic. Within the groups, we had mutant and wild type. Now it's the other way around. We look at mutant and we look at wild type. So first comes the mutant, and these are astrocytomas. Then comes, they are all astrocytomas. The wild type is GBM. So when I look at astrocytomas, and we said we are retaining the grading of the histopathology, the better prognosis is grade 2, the worst prognosis is grade 4, and that is determined by the presence or absence of necrosis and microvascular changes. So astrocytomas and oligodendrogliomas are defined by the presence of an IDH mutation. They all have this in common. They are distinct by other mutations such as P19. IDH wild-type GBMs, we have to be careful. From a histological point of view, they can look like low-grade, but the clinical behavior is high-grade, and they are defined now by the genetic profile, which is wild-type. So, adult diffuse gliomas, now, there are 3 types: astrocytoma, oligodendroglioma, GBM. You have 3 markers, which are important: IDH, 1p19q, co-deletion. This one I didn't talk too much about it. And astrocytoma itself, you again have 3 grades, but you don't talk about anaplastic anymore. That word has disappeared. The MR characteristics, most important for you is to know the flare T2 mismatch, and this is something you have to use in your clinical routine. If you do spectroscopy, it is challenging. It is easier with 3 Tesla than with 1.5. You have to work on it hard so that you can see, and you have to develop your own database to be able to look back to, on this. ADC, contrast perfusion, and intratumoral susceptibility combined can be of help. Now, it depends whether you have your pathologist doing the genetic testing or not. If the pathologist is doing the genetic testing, I don't think you need to put a lot of effort in trying to do this, because they are going to give you the gold standard. But if the new pathologist is not doing this, because it's expensive, because they don't have the tools, it's a big problem whether you can do this or not, then these information become critical in trying not to give 100% diagnosis, but a higher percentage, larger than 50% diagnosis in terms of what IDH type it is. With that, I would like to conclude. Thank you very much.